Welcome to the Ticktective podcast, a program of the Bay Area Lyme Foundation, where our mission is to make Lyme disease easy to diagnose and simple to cure. I'm your guest host today, Dana Parrish. I'm the co-author of the book Chronic, and I'm on the board of Bay Area Lyme Foundation. This program offers insightful interviews with clinicians, scientists, patients, and other interesting people. We're a nonprofit foundation based in Silicon Valley, and thanks to a generous grant that covers 100% of our overhead, all of your donations go directly to our research and our prevention programs. For more information about Lyme disease, please visit us at bayarealyme.org. Hi, I am Dana Parrish, and I'm so excited to guest host the Ticktective podcast today on behalf of Bay Area Lyme Foundation, of which I've been a board member for the last 5 years. I want to introduce you to a very dear friend of mine, one of the most brilliant, curious, interesting, funny, dearest people. Anyway, please welcome Dr. Charlotte Mao. She is a pediatric infectious diseases physician with a special focus on Lyme disease and associated infections. She received her medical degree at Harvard Medical School, did her pediatric and infectious diseases training at Boston Children's Hospital. The first 25 years of her career were focused primarily on pediatric HIV clinical care and clinical research, serving as a site co-investigator for numerous NIH-funded multi-center pediatric HIV clinical trials at Boston Children's Hospital. She turned her focus to Lyme and associated diseases after gaining extensive clinical experience with pediatric Lyme patients in Boston Children's Hospital's referring ID clinic. Then she joined the Pediatric Infectious Disease Department at Mass General Hospital and Spaulding Rehab Hospital Dean Center for Tick-borne Illness, where she was the pediatric ID specialist in a multidisciplinary clinic for children with complex Lyme disease. She is currently curriculum director for Invisible International. She most recently served on the Tick-borne Disease Working Group Subcommittee for Prevention and Treatment and co-organized a Cold Spring Harbor Laboratory Banbury Conference on perinatal transmission of Lyme disease. She is also on the Bay Area Lyme Foundation's scientific committee. Welcome, Charlotte. It's so great to see you.
It's wonderful to see you, and thank you for that lovely introduction.
So I really love your story so much about how you transitioned from an HIV specialist into learning so much about Lyme disease and its associated infections. Would you share a little bit about that?
Sure. So as you said in the introduction, I really was focused for the first part of my career on HIV. And it was when I started seeing lots of patients in a general referral ID clinic at Boston Children's Hospital, a clinic where pediatricians refer all types of infectious disease problems. And it turns out that this is in Boston in the northeastern United States, where Lyme is highly prevalent. Lyme disease was the single most common reason for referral for which I was seeing kids in this clinic.
Wow.
And it was actually an enormous learning experience for me. I entered, with the standard teaching that I was taught as a medical student and in my pediatric and infectious disease training. And I gradually came to realize, I think this is a narrow view that doesn't begin to reflect the full complexity of this disease. It took a while, actually. It was over a couple of years, very gradually, as I saw many cases. And if you think about it, if a pediatrician's going to refer a case for specialty evaluation at a children's hospital, it's going to be a more atypical case. It's not going to be, the standard presentation or standard response to treatment, because then the pediatrician wouldn't need to refer it. So I was seeing cases that at least are considered atypical according to the standard paradigm. But everything in medicine is pattern recognition. And as I started seeing repeated kinds of presentations and things that weren't something I was aware of that Lyme disease could present as, I was reading very deeply into the primary literature, both basic science and the clinical literature. And I realized, wow, there's a lot in the primary literature that speaks to a much more complex constellation of symptoms.
Absolutely.
And, then I was hooked and basically reading everything I could about Lyme disease, and really trying to educate myself. And it really led me to turn the focus of my career to entering Lyme disease treatment and care of kids with these complex conditions.
Was it surprising to you how controversial this topic of chronic Lyme? And, I speak to a lot of physicians, and, I went through my own chronic Lyme illness, 2014, where I was dismissed, like there's no such thing. I saw 3 infectious disease docs. They said, it doesn't even exist. It's a fake disease and all kinds of stuff. And it was like so demoralizing to go through that. And as a clinician, when you're learning certain parameters and guidelines, is it kind of like mind blowing to really go down the rabbit hole and go like,
It was. I actually used that word. I felt like I was going down the rabbit hole as I was learning about Lyme disease. Because I knew that there was some controversy in the field, but I didn't know details or the depth of it. And I did have this idea that, there's these patients who think that they have chronic Lyme, and there's a group of physicians who are sort of alternative or even somewhat fringe, who see these patients. And I think that the attitude or the view that physicians are taught is to have anything from really, I would say it's anywhere from skepticism to derision is how I perceived was the view of the patients and the other clinicians that cared for these patients. So as I started to realize, wow, I think that there might be some validity to this other point of view, it was a very eye-opening experience, I would say.
Yeah, there is so much literature that speaks to and references chronic Lyme, even from, and especially from, the Infectious Diseases Society of America, the IDSA. And so there was a huge body of incredibly wonderful research done. And then at some point, it sort of stopped, it sort of tapered off, and the whole thing changed. I reviewed a Newsweek article recently from, I think, the 80s. I'm sure you read it, where it was on the front cover of Newsweek saying, Lyme, they were comparing it to HIV in this article and saying if it wasn't for HIV, it would be the biggest and worst disease of our time.
Mm-hmm.
And it talked about congenital Lyme, and it talked about how prevalent it was in California and all over the place, and how many people were sick from it. And it was this wonderful in-depth article that just sort of laid it all out. And now we don't even acknowledge any of these things as being true anymore. It's the most crazy thing to think an infectious disease. It's so prevalent all over the world has been politicized. It's just so sad for patients. You've been such a gift to the Lyme community because obviously you are Harvard trained physician, scientist, and with the most incredible bedside manner and brilliant mind. So I've heard from many of your patients over the last few years, how grateful, how many of them that you've made better. What should parents look for? What are the signs of Lyme or chronic Lyme in children?
Lyme can present in children in the same ways that it can present in adults. So there are what are the most commonly recognized manifestations. Of course, there's the so-called bullseye rash that can happen at the site of a tick bite.
Right.
But in fact, it's often not a bullseye appearance. And that's important to know. More commonly, it's homogeneous. So it's red throughout instead of that target bullseye appearance, but it has an expanding progression of the rash.
Do people always see the rash?
No. So that's another important thing is that there's lots of people who present without any recognition or recollection of having a rash. And the estimates for how common the rash are vary widely. Often it's said, even up to 70 to 80% of people will have the rash. But when you actually look at, for instance, the earliest papers that described, this is now Lyme arthritis, but in that only 25% of people recalled having a rash.
That's a big deal for people to understand.
Yes.
You don't have to have the rash in order to have Lyme. So are there strains of Lyme that don't produce a rash even? Because I know there's so many strains now that we're dealing with.
Well, that's something that really needs to be studied more, is, different, if you want to say, variants or strains of the bacteria, the Lyme bacteria, which is called Borrelia burgdorferi, and what kind of manifestations they can manifest with. And that's something that was studied sort of earlier, you can find in the historical research literature, but didn't really get fully fleshed out and didn't continue to be studied. So I think that is something that definitely deserves more research.
You just made me think too about Lyme's discovery in children was made because of a cluster of kids who got juvenile rheumatoid arthritis in Lyme, Connecticut. Do you see that commonly? Do you think that juvenile RA is highly associated with Lyme?
Well, Lyme has been very aptly dubbed the new great imitator because it can mimic so many other conditions. Interestingly, the first great imitator was syphilis, which is also a spirochetal disease, similar to Lyme disease, can present in, if you want to say, stages, with a wide variety of manifestations, multi-symptom, multi-systemic symptoms. So going back to your question about the arthritis, yes, some still that can be the first manifestation in children, just as it can be in adults, that all of a sudden you present with a swollen knee, often swelling out of proportion to the pain. Lyme arthritis, it does most commonly affect large joints, often a single joint. But important thing to know is that, yes, that is the most common, but in fact, it can present in a whole variety of joints, including small joints. And that was something I was very surprised by when I went to the original papers. And really, when you go back to the historical literature and read the papers that the earliest researchers wrote, just beautiful clinical descriptions of the really heterogeneous symptoms and signs that could be seen. And there I was so surprised, because that's what pediatricians are always taught, a large joint monoarthritis, meaning it affects a single joint. But in the paper, it says that occasionally it could present in the small joints of the hands and feet. Yeah. And in fact, it was in 30% of patients.
Wow.
That's more than occasional to me.
That's a lot.
Yeah. So
I didn't know that.
That really surprised me when I read that.
That's very surprising. Wow. And I also feel sometimes when I talk to parents whose kids have growing pains, as they say, I'm often suspicious that growing pains could be associated with vector-borne diseases like Lyme. Do you think that's a fair thought to have?
I think it is. I had growing pains actually growing up. And I think it's a real phenomenon. It's not just that, the kid is complaining of pain without really an organic reason, as we like to say in medicine. And my personal suspicion is that actually a common co-infection of Lyme called Bartonella, that maybe it is could be a root cause of growing pains, but that's just my personal suspicion. I'll just add to that very interestingly, in around World War I, trench fever in soldiers from World War I is caused by another species of Bartonella. And in fact, shin pain, deep-seated shin pain, was something that was described in an article about trench fever. So that's one reason
What
I
is
have
trench fever? Can you describe trench fever a little bit?
Yeah, so it was a febrile illness that was seen in soldiers in World War I when they were in the trenches, and it was similar to cat scratch disease, which is the most common manifestation of Bartonella that doctors generally know about. It is transmitted by, in the case of cat scratch disease, it's a flea that the cats have. And what can happen is they groom themselves, and they can get the bacteria on their claws, and then they scratch you, and you get what can be basically a swollen lymph node in the area that drains the site where you were scratched. So if you're scratched on your arm, a swollen lymph node in your armpit. With trench fever, the insect vector that transmits it is the body lice that affect the body. And so you could imagine that soldiers are in cramped quarters in the trenches. And that's a ripe environment for something like body lice to spread.
Oh my gosh, that is a horrifying thought. So talk to me about kids and the psychiatric, what I hear a lot from parents is, my kid, it was like a light switch turned on or turned off in their brain, where they changed overnight. Their personalities changed overnight. I hear about this so much. They get sudden anxiety, depression, insomnia, OCD. They're throwing a chair in the classroom where they were the most well-behaved child, or their grades are getting poor. They can't concentrate. Do you see this a lot? And can you talk a little bit about neuropsychiatric?
Yes, I did see it a lot. And I think that psychiatric and neuropsychiatric manifestations of Lyme disease and associated infections, including in particular the Bartonella that we were just talking about, are very underappreciated manifestations. It was something that I really was not aware of when I started seeing Lyme patients. And in fact, again, when you go back to the historical literature, many of the early reports of neurologists who were seeing patients early on, including kids, described psychiatric manifestations. It's very interesting that, as I mentioned before, syphilis, another spirochetal disease that can be the great mimicker, well, that could also present with psychiatric manifestations. And in fact, at the turn of the century, a large proportion of patients who were in, if you want to say mental institutions, syphilis. So yes, things like anxiety, depression, you mentioned the rage. This anger, aggression, rage is felt more characteristic of Bartonella by clinicians who see a lot of these patients with complex Lyme disease and associated infections. And OCD type of behavior, obsessive compulsive behavior. And in fact, many of the manifestations, there is, I don't know if you would say really an overlap, but there is a constellation, a syndrome called PANDAS, hands, of which Lyme disease and associated co-infections can be a trigger for. So that is pediatric, PANDAS stands for pediatric autoimmune neuropsychiatric disorders associated with strep, the strep bacteria that causes strep throat. And this was first described in the late 1990s by a researcher at the National Institute of Mental Health, who at that time, it was initially described as children who presented with sudden onset of OCD behavior, as well as motor tics, TICS, the kind of, not ticks, the insects. And it was noticed that this could happen in the setting of a strep infection or a recurrent strep infection. And what was postulated is that there was a similarity to this with what is called Sydenham's chorea, which is a manifestation of rheumatic fever, also well-known post-streptococcal phenomena. It can present with a variety, a constellation of manifestations, for instance, arthritis or carditis, inflammation of the heart, valvular involvement being potential manifestations. But then the Sydenham's chorea is a movement disorder, but it also has, and a lot of doctors don't realize this, I didn't at the time, that it can have prominent psychiatric and neuropsychiatric manifestations.
I didn't know that. That's so interesting.
Yes, it's so interesting. Very famous physician named William Osler, who's considered the father of modern medicine. He's sometimes called that. He actually described in the late 1800s, he had a manuscript or a book on chorea and choreiform affection. He described these children with Sydenham's chorea and the neuropsychiatric manifestations that they had. And it's just striking to read it because it really makes you think, wow, this sounds very similar to what you see in kids with pandas, the kinds of neuropsychiatric manifestations that they have. So yes, that is, I think, a significant and very, these kids, it's a very significant manifestation in children, and they can be severely affected, where it's really life-altering symptoms that are extremely distressing, both for the child and the family.
Yes, one of my dear friends has a son who has PANS, and been going through it for 5 or 6 years. You've been so helpful to this family, and it's devastating. It's just absolutely devastating. It was one of those light switch cases, and I knew him before, and he was just happy, healthy, go lucky kid, and then all of a sudden, boom, just completely changed in every way, and body pain and nausea and severe OCD, and couldn't sleep anymore. And I'm so glad that we can talk about PANS, because so many physicians don't really know about it at all. I don't even know that it's so controversial, more than it's just not recognized as much as it should be. Like, where should parents go? Like, how do they even get a diagnosis? And what hope is there for them to kind of lead them on the right path and lead them out of this, because it's so devastating. And I'd love to hear about some of your cases, your hopeful cases. I know you've helped a lot of kids.
Yeah, so I would say, as I learned about this disease, I was so impressed with parents who really trusted their intuition. They knew their kid, and they knew there was something more than what they were being told. And they kept at it. And frankly, they educated me. And so I would say, because Lyme disease and these associated infections can present a very confusing constellation of symptoms and signs.
Right.
And because we aren't well taught as physicians about the hugely heterogeneous symptoms, it's no surprise that doctors won't necessarily consider Lyme disease or one of these other associated infections.
Just so common. I think it's so underappreciated as you're talking. It's just blowing my mind how many people that you and I just both know personally in common, just in our regular old life, not even in the Lyme world, that have been affected. So I
agree with you. Yeah. I think it is much more common than is generally realized by either the public or the medical community. And frankly, a lot of people do not have symptoms. You can have infection with these organisms and have no symptoms and stay that way for your entire life. And that's what's so confusing.
Yes.
So is it, a certain strain that causes different manifestations in one person versus another? Is it the host themselves, some type of genetic predisposition? Is it the other co-infections and the other hits?
Is there a tipping point for us humans?
Yes.
And I also want to talk to you about latency, because I think that's a huge issue that is so under-recognized as well, where you get the initial bite or infection, and then you have a long period where you may feel pretty good, and then boom, and you don't connect it back. So,
Yeah. So I do think that in many of these patients who present with a more complex and prolonged constellation of symptoms that don't respond to standard treatment courses, that what you are dealing with is a multiple hits model of illness, where Borrelia burgdorferi, the agent of Lyme disease, is just one hit, one infection. There can be a multitude of co-infections, some of which are also transmissible through a tick bite. But frankly, other ones that can just be infections acquired in other circumstances. Say, for instance, with Bartonella, it's considered controversial whether it's actually transmitted by ticks, even though the organism has been documented in ticks, different tick species all over the world. But whether they're actually efficient vectors to transmit it is not clear. However, it's transmitted by a multitude of other insects. I mentioned, the lice for one species of Bartonella, fleas for another, and
spiders.
So yes, it could be another, it could have been a pre-existing infection also that was asymptomatic or latent, as you mentioned, but then boom, you acquire these multiple hits over time even. And one of them can be, if you want to say, the straw that broke the camel's back, or the thing that makes your bucket overflow, and finally you present with symptoms.
Yes, I feel like I see that. I have to say, in this day and age, I would feel remiss not to mention how often I think I'm seeing it where COVID is activating latent or pretty minimally symptomatic cases of Lyme and Bartonella. Just because, I hear from so many Lyme patients who got better and they relapse after a COVID infection with the same symptoms. They get retreated for their Lyme and Bartonella and they get better. So, I mean, I don't know. Yeah, it has to be studied, but I feel comfortable at this.
Absolutely.
I feel comfortable speculating because I feel like
I do too, because of how commonly it gets reported.
Can we also, just since we're touching on COVID, talk a little bit about the overlap in symptoms between Bartonella and COVID? I'm going to talk to Dr. Ed Reichwart later today, more in depth about this as well. But is there? I see an overlap, but I'm not the doctor. So what do you think?
Yeah, what I do wonder about is exactly what you described. Are these pre-existing asymptomatic or maybe minimally, mildly, moderately symptomatic? It's the whole spectrum that you can even have intermittent symptoms with. It's not like the symptoms are continuous. These illnesses are, it's their very nature that they can be relapsing, remitting illnesses.
Yes.
And then you get this additional hit that can really trigger the infection to become active. And so, yes, in terms of the symptoms, we mentioned before, for instance, neuropsychiatric manifestations. I have seen in my, my patients who have, say, complex Lyme and Bartonella, that their anxiety is a very common symptom. Of course, it's a common symptom overall, but sometimes it can be in patients almost a physical anxiety.
Yes. And internal vibrations too. We hear a lot about vibrations.
Yes, that's an unusual symptom, but one that, clinicians who see a lot of these patients think could be more associated with Bartonella again.
And COVID. We're hearing it so much with COVID, right?
Yes. So could COVID be activating Bartonella, just as you described before? It's logical to think that perhaps that could be the case. Other infections can do that. So why not COVID?
Yes. And it's kind of a weird, an unusual symptom to describe. And yet you and I hear it described historically with Lyme, Bartonella, probably more Bartonella, so frequently. I mean, I had it, and I know you've had patients with it, and it's just so bizarre. I am part of some long COVID groups just because I've done some interviewing for the book about COVID. And so I'm really interested in the patient experience and what the researchers are learning. And they all talk about this internal vibration feeling. And it's finally being studied and taken really seriously. I think it was one of those weird things that nobody knew whether it was real. Clinicians would sort of go I don't know, I don't know what to tell you about that.
Yes. And I feel, I do think that symptom is maybe more reported by adults than children.
Yeah.
Why that's the case, I don't know. Is it that you have the organism for longer? But
that's interesting. That's an interesting delineation to hear, that there's not as much of an overlap with kids with that symptom.
Or maybe do they not have the language to, be able to describe that symptom? Because it is such an odd symptom. A lot of times adults don't want to report it to their doctors because they think it sounds sort of crazy.
I would describe it like I was being plugged into an electric socket. And there was just a current that would go through my whole body. You couldn't see it necessarily, but I'd wake up with it. It's a really, really intense and scary because you don't know if it's some neurodegenerative thing taking hold. If you're me and you're thinking of, oh my gosh, I have Parkinson's, you don't know what it is. It's really scary.
Yes, it is.
As you know, these are my 3 a.m. panics. So one of the things that you have taught me so much about is the role of mold in these cases. And just I'm not talking about exclusively kids, adults too. It's so under-recognized in the medical world, yet I looked online before our conversation just to see but the CDC acknowledges the severity of mold. And there's so much research on how toxic they can cause cancers. They can be used in biowarfare. They can totally poison people, literally to death. And you do hear about this with adults. I can't speak to kids saying this, but this feeling of being poisoned, I have heard that many, many times. And then people go on sometimes to discover that mold is playing a major role in either their illness or in holding them back from healing. What is your take on all of this?
Yeah, so mold, and specifically its toxins that the mold produces, or they're called mycotoxins, are what we're talking about here that can really impact patients with persistent Lyme and Bartonella and other co-infections. So it's something that I actually learned about as I was seeing patients in this clinic for kids with complex Lyme disease, and other physicians had diagnosed one of my early patients there with a number of mycotoxins complicating their illness. And it's interestingly something that doctors really are not taught about in medical school in their training. So what we are taught is that mold can cause invasive fungal infections in people who are immunocompromised, for instance, transplant patients, and also allergic type disease, for instance, asthma. But the idea that mold toxins could complicate a chronic persistent infection like Lyme disease or Bartonella is something that really is not recognized or discussed in standard medical training. But it is, again, when you go back to the primary literature, there is a lot of literature, interestingly, in the veterinary literature, because animals get exposed to these mycotoxins in their animal feed. So the two places where you can get exposed, it's it's natural to get, everyone's exposed to
Yeah.
some mold in their food. It's just in the food supply.
Right.
But the other major place is in water damaged buildings that get contaminated by mold. Again, lots of people are exposed to this.
Right.
So why are only certain people so dramatically affected? I would say that this is an emerging science, and a lot more research needs to be done in the area. But there are a group of clinicians who really have seen many patients with mycotoxin health-related effects and have really developed expertise in this area of how to manage these patients. And what I was seeing, what I was taught and what I found in my patients is that if you have a patient with, say, persistent Lyme symptoms, Bartonella symptoms that hasn't responded well to standard treatment, you need to think, is there something else that's, another hit that's preventing them from being able to respond well to treatment? And mold toxins are, I think, something that can be a common hit, and that in a subset of patients can have a very negative impact. There can be overlap in symptomatology, but also effects that basically make it difficult for that patient to respond to treatment.
I found it very interesting to learn about the neurological impacts of certain molds. Can you talk a little bit about that, and also the neuropsychiatric impact?
Yeah, so there are certain mold toxins that have been well delineated to cause neurologic and psychiatric symptoms, absolutely, including, for instance, there's even ones that are called tremogens because they cause tremors. What I think, it's unclear what is the actual mechanism in, say, patients with Lyme disease or Bartonella, complex Lyme disease or Bartonella. How is mold making those or worsening or making manifest those neurologic or psychiatric symptoms? But one thing that I think could be possible is that basically they are worsening the co-infections, the Bartonella or the Lyme, and so making them making their neuropsychiatric and neurologic manifestations more severe.
I sent you this episode of a show about a family who was all poisoned. It was a documentary style show. It wasn't a fictional representation, where they all died. The mother, I think she was the first. She had gotten, the husband, he was very young. He got,
yes, I remember that,
dementia. And the kid got really, it was like horrific. And that's an extreme case, but very, very common, very, very commonly under-recognized. Like, nobody's talking about this. And I find it extraordinary. I think it's probably responsible for so much chronic illness, so much asthma. My friend's son developed asthma when he was around 9 or 10, and she had an inkling that it could have been mold, and she had people come over and evaluate the house. She was correct. They remediated the mold, and her son's asthma went away. So I hear these stories, and asthma's like the tip of the ice. Asthma's the obvious thing, right? As you sort of the one we think of. But when I think about its role in neurodegenerative diseases, like that case, who knows how often that's happening. We know infections can also cause dementia and neurological and neurodegenerative diseases, but these things just seem so symbiotic to me.
Yes, I agree. They're all very common in and of themselves. So having them occur in combination is also something that you can see, I think, much more commonly than is recognized.
As I talk to you about all of this, I realize how uncommonly physicians consider root cause.
We aren't taught about mold, that issue of mycotoxicosis, and it's maybe even more controversial than Lyme disease, and whether this area is recognized as being something that is, a valid health concern that can cause these symptoms and signs in patients. And so it does take a patient really, I guess, trusting their own intuition and keeping at it and doing some research on their own.
Yeah.
And then asking, physicians are willing to learn, absolutely. They want to help their patients, but
Sure.
have the education. And so if I was always happy if a patient educated me about something new, and there's a lot that needs to be taught in all these different illnesses. They're much more complex than what physicians are generally taught. And then when you put them all in combination, then you're dealing with a whole nother level of complexity.
Yeah, no, I can totally appreciate that. It is a complicated stew. And it's a miracle when we do find doctors like you and when we do get to the right care, because it's so confusing. It's such a confusing maze for the patient. And I can say I saw 12 doctors and most of them really wanted to help me and were trying. Especially I'm thinking about my internist. She knew me for a long time before I got Lyme, and she knew that wasn't crazy, and she was concerned about my symptoms, but she just truly did not know why I had them. And then when I went into heart failure, she was so concerned, but again, nobody, not even the cardiologist at the time, considered that it could have been an infection. I kept saying, could it be from the tick bite? Could that, all this weird new stuff, fibromyalgia, and I did have a lot of neuropsych stuff, anxiety and depression, and could it be from a tick bite? And they all said no, so I feel like it's great to hear you say, be educated, come in with some information, some data, maybe even some stories like the ones we're going to talk about today, and present them. Because I think doctors a lot of them would be super open to it. It's just, there's a big black hole in medicine around these issues. I'd love to hear about some of your mold cases. I know you've had some really fascinating, at least if you don't mind talking about one or two where, you discovered that might have been a root cause.
Well, I would say in a number of the pediatric cases I saw with prominent neuropsychiatric and psychiatric manifestations of a PANS-PANDAS-like presentation, it turned out that mold was a big triggering factor. And in at least a couple of cases, the home was found to be very contaminated with mold in the basement. Interestingly, it was when the Christmas decorations got brought up from the basement to the home that
I did not know that.
different kids became, who already had complex Lyme disease and Bartonella and basically a PANS-PANDAS kind of picture, markedly worsened or re-worsened. And then in turn, when the mold, in one case where the mold got remediated in the house, remarkable turnaround in the patient.
Can you talk more about the clinical symptoms and the resolution of those symptoms?
Yeah. So again, it's the kind of presentation that you see with PANS-PANDAS. Intense OCD behavior, anxiety through the roof. You can see oppositional behavior or anger, aggression, rage kind of symptoms. You can see physical kinds of symptoms as well. That's part of the PANS-PANDAS complex. So for instance, urinary voiding problems are something that get described. For instance, kids who, had no problem, all of a sudden are wetting their beds at night.
That's so interesting.
Yes. and restrictive eating. That's another, almost like an anorexia type picture, but sort of obsession
Yes.
around restricting the eating only to certain things. It's sort of like that's their version of OCD. You can see even suicidal ideation that is obsessive. That is their version of OCD. You can see the tics, of course, as I mentioned before, the motor tics. You can see learning problems, basically cognitive problems. In PANS Pandas, it's described sometimes kids, they can have a real drop off in their penmanship ability, their handwriting. So it's a whole constellation of symptoms like this. And any combination of those symptoms, multiple of them, just a couple of them, and also actually another physical sign, going back to the physical signs, there is a certain kind of rash. It's called a streaked rash or a striae-like rash that has been associated with Bartonella infection, where you can see often on the back, sometimes very prominent, these streaked lesions, but also in unusual areas. Sometimes it could be, say in the groin or under the arm, and they can be sometimes fiery red, but then sort of fade to look more like striae or stretch marks that, for instance, women see when they're pregnant on their belly. So a child with neuropsychiatric symptoms and a rash like that, you need to think about Bartonella.
Again, we should say how common Bartonella is. Were you the one I was talking to about how Bartonella really wasn't recognized so much until HIV, right?
Yes. Well, the agent of yes.
But I think it was just not recognized. I don't have HIV, and I had a very, very severe case of Bartonella that caused heart failure and a multitude of other things. And I am convinced I also had Lyme, so there's an overlap. I don't want to say I know 100%, but I'm very suspicious, just given all I know about these organisms, that it was Bartonella really driving my illness, and how difficult it is to eradicate. But I think we need to just reemphasize, it's so under recognized in medicine, but it's still so common in the population, and it's all over the world. It's common in Asia. People think these are just Northeast problems. These are, if you live in Connecticut or if you live in Vermont, you have to worry about it. That's completely not true. It's all over the place.
Exactly. Yeah. There was actually a study that recently came out, published by a Chinese research group, and they estimated that 14% of the world population is infected with Borrelia. That's enormous.
That's enormous. And it's still probably, frankly, given the poor quality of our testing, an undercount. It's still probably more. The CDC keeps doubling, tripling its numbers about what it estimates. I think it's huge. It's huge. And it's been the elephant in the room for so long. I think finally COVID may have opened the door to talking about and understanding better what a horrible multisystemic infection can do. So now we can say, so doesn't it make more sense when your patient comes in? I've talked to doctors. Now what the Lyme patients have been going through. We're saying we have weird sensation, we have brain fog, we have this, we have joint pain, we feel weird, we can't concentrate, we're tired. All these kinds of things where you weren't believed. Now everybody's going, oh my God, I think
I think there's a lot for the long COVID treating community to learn, and research community to learn from clinicians and researchers who have studied long Lyme.
Yes. Absolutely. Now, congenital Lyme is a really, really important topic that I know you know so much about. So congenital Lyme means that a mom who's pregnant can pass it on in utero to their baby. So can we talk a little bit about that? Is it real? Is that really happening? Because I know
Yeah, so
controversy, but
it is real. Absolutely, it's been shown that Lyme can be transmitted from pregnant mom to her baby. What isn't known is how commonly it occurs. What is the range of adverse outcomes for that transmission? What are the best treatments for mom? There's studies, a systematic review that was done a couple of years ago by Canadian researchers, as well as researcher from the CDC, showed that there clearly seems to be improved outcomes when mothers are treated compared to when they're not. First of all, I should say it's an area that absolutely needs more research. Research was done sort of earlier maybe in the reports, and some research were done in the, say, 80s and 90s. But then there's really been a quiet period where, because some of the epidemiologic studies that were done, say, in the 90s, there seemed to be the feeling that, oh, maybe this isn't as serious or as frequent a risk as we were initially concerned it might be. And then sort of attention seemed to fall away from the issue. And yet the early case reports were of babies severely affected. We're talking about infants that died, either, it could be stillborn or spontaneous abortion or early neonatal death, so shortly after birth, in babies who, on autopsy, the spirochete was shown in different organs. And so, there you have a definitive case that the spirochete was transmitted from mom to infant. But then the studies that were done subsequently showed a real range of heterogeneous outcomes. And the feeling was, well, there's no sort of congenital syndrome that's shown up. And so maybe those were all just coincidence. However, as we've been talking about through this whole interview, Lyme presents in children and adults with such heterogeneous symptoms. Could it not be the same in children? So really, I would say that the early case reports raise some real concerns. There are studies in animals that have raised real concerns too, and that a lot more attention and research needs to go into this topic.
I agree. I think it's I'm just going to go on a limb again and say, I think it's very prevalent. And I have always found it curious that so many kids get diagnosed with Lyme and parents never see a tick bite, and the kid never sees a tick bite. They have symptoms, 2-3 years old, the kid's knees hurt. All of a sudden they stop walking. They don't want to walk anymore. And I hear all kinds of stuff like this so commonly from parents. And, you would imagine that if you have a baby or a toddler, you're going to notice a tick bite on them. You're giving them a bath. You're constantly, it just doesn't make sense to me that it's all vector-borne. It makes sense.
Yes, I would say that just, in seeing my patients, when you get a really complete history of not only the child, but also their siblings and a family history, I wondered in a number of them, could this be a case where actually they acquired the Lyme vertically from mother to child? Sometimes when the mom wasn't even diagnosed herself with Lyme disease, but described to me a constellation of symptoms and signs over time that made me think, maybe she is in fact infected with Lyme disease. And interestingly, so we talked about syphilis before, how it was there are many overlaps, parallels and overlaps between syphilis and Lyme. And again, congenital syphilis is something that's well recognized. And the manifestations in children who acquire syphilis congenitally, it's a very heterogeneous range of manifestations as well. They can present both early or later, decades later. And so what you brought up before about a child who all of a sudden presents, say, with joint symptoms and an arthritis, and there's no recollection at all of a tick bite. Well, it's an interesting thought. We, of course, need to study this more to prove it, but could that potentially be a late manifestation of an infection transmitted at birth? It's not a crazy thing to think.
You hear it so much, at some point the light bulb goes on and you think, and I do see, because I think Lyme is so ubiquitous in the population and it's often asymptomatic or minimally symptomatic. I also know that it can cause fertility problems. And I see these patterns, and I really hope this research gets done. And I was thinking about this case that you told me about a few years ago about OCD. This is not on the topic of congenital Lyme, but a child with OCD who had her tonsils and adenoids removed. Can you talk?
Oh, yes.
Talk a little bit about this? This was fascinating to me.
I know what you're talking about. It's a different case. This is a really fascinating case series of PANDAS patients.
Yes.
Reported by researchers at Stanford. And one of the cases was I think she was a young teenager with very severe OCD, who also happened to have chronic recurrent sinusitis problems, and had been identified on imaging studies to have a cyst in her sinus. So this is interesting because there is also this thought by a number of physicians who see these patients with complex Lyme disease and Bartonella that either of those infections can potentially be associated with cysts forming in different areas of the body. Now, it's well known, sorry, I'm going to take a little aside here, that Lyme, for instance, can cause a Baker's cyst, which is a cyst behind the knee. Sometimes those can even rupture and cause, severe pain and symptoms. Many cases described in the literature of Lyme disease presenting with a Baker's cyst. But in this, going back to the teenager with PANDAS PANS, she had sinus surgery done to remove the cyst. And there is actually a quote of from the patient right in the article, in the journal article. And she says, when they took that cyst out of me, they took the OCD right away with it. And that was just eye-opening to read that. Does make you wonder, could it be possible that a cyst could form just like it does behind the knee? Could it form in the sinus? A lot of times we see those and we just think of those as being incidental cysts that just happen to show up on imaging and don't really have any kind of clinical relevance. But something like that has to at least make you wonder, is it possible that it could be a manifestation of one of these infections that's contributing to these psychiatric symptoms? Fascinating case.
I think about it a lot. And I remember, Neil Spector told me at some point, like, there are some people that are just very cystic, and he sort of off the cuff just talked about a parasitic infection that, frequently causes cysts.
In the case of parasites, it's as if the body is trying to wall off this infection, this organism. So it sort of gets encased in this cyst. And those are described with parasite infections. For instance, it could be in the brain, there's something called neurocysticercosis, or in a muscle, or in a liver, a parasitic infection called echinococcus. So is it possible that the same thing is happening with, say, Lyme or Bartonella, where the body is walling it off? It's really interesting thought.
It is. And it's also interesting that there's this other dimension to this whole illness, which is parasites. We don't have to get into that. Well, we could do that another time, but I wasn't even thinking along those lines, but that's another hit. And I think that it's a misconception that it's not common or it's not possible to get parasitic infections in the US. There's a lot of, people say, oh, it's so rare. But again, we've found out over time that many things considered rare are actually quite common.
I do think that parasitic infections are more common even here in the US, and that they can, similar to, we've talked about the mycotoxins before, but they're yet another hit that can complicate the response to treatment. And at least again, more research needs to be done in this area, absolutely. But the thought is that things like mycotoxins, or one potential mechanism by which these parasite or mycotoxin hits can complicate response to treatment, or can worsen these infections like Lyme and Bartonella, is that they pull the immune system in a certain direction that's sort of different from the direction it would go to respond to an infection like Lyme or Bartonella.
These should all be on the differential. As we're talking, I realize like the list just keeps growing about the things that we need to rule in or out when we have kids that are presenting with non-obvious, in complex problems. I think infections, parasites, mold, these environmental, there's so much environmental, there's chemicals in our food, there's glyphosate. I mean, all these things are playing a role in chronic illness, and it's so frequently being missed and just not really being addressed, not being talked about in the medical community. And I know parents are going to want to know about testing their kids, because we know the testing is very, very, it's not great. It's pretty bad, and it's not a secret. What are the best tests, just generally speaking, that parents can ask for and advocate for? What kind of a doctor should they be seeing? How do they even approach this? Where is the best starting point if you're worried about your child having Lyme?
Yeah, that's a very good, excellent question, and complex. So, we talked before about the controversy in the field, and testing is one of the big controversies. So, the standard approach to testing is to do something called a 2-tiered Lyme antibody test. And the general thought is that patients with early Lyme disease, it's well recognized that those patients can test negative because it takes time to develop the antibody response. However, the sort of standard teaching is that patients with late Lyme disease should have an antibody response on this test. And yet, when you actually go back and look at the primary literature on which the criteria are based, it's very interesting. Surprisingly, there's so many things I was surprised by when I started really researching the field. The diagnostic criteria are actually based on a single study. And the study, it's not a particularly large study. And in fact, when you look at the study itself, there were 2 parts to it. There was a retrospective review of patients who had already been diagnosed with Lyme, and then a prospective study. So that's looking forward at newly diagnosed patients. And they reported how sensitive was the test that the testing criteria that they had developed or that they were proposing in a variety of different patients, including patients with arthritis, patients with neurologic presentations. And the arthritis patients, they do tend to test positive and very positive on the Lyme antibody test. It's the neurologic Lyme patients where you don't see as consistently positive testing or as strongly positive testing. This is very important. In that study, in the retrospective portion of the study, I think for the neurologic patients, it was 72% were detected as positive. And in the prospective portion of the study, it was 84%. So that means that you're missing anywhere from if it's 72%, you're missing up to 28% of cases. If it's 84%, you're missing up to 16% of cases. That's a lot to be missing.
It's a lot.
And that is not something that I think has been well addressed. And so the important thing for physicians and patients to know is that although this two-tier testing is standardly used, it will miss a lot of patients who are in fact infected. And there are ways to get more sensitive testing. You can use specialty labs that will look, that basically do more complete analysis. And so I would say, if your child has a confusing constellation of symptoms and signs where no one seems to know, exactly what's going on, and they test negative on standard testing by Lyme disease, and research about the symptoms, the potential symptoms and signs of Lyme disease, and if you think that it should be something that should be considered more in your kid, then I would ask your physician about doing testing at one of the specialty labs that does more complete testing. Now, it might be that your physician is unaware of that type of testing or how to get it. And then, there is a group of clinicians that are very well versed in using these specialty labs and who frankly take a broader view of Lyme disease than what is standardly taught. So it might be that you will want to consider having a second opinion with one of those clinicians and asking about evaluation for Lyme disease and diagnostic testing.
How do we find them? How do patients get, I don't even know where, do we send them to iLads or?
Well, iLads is one organization that has a roster of physicians who do take this broader viewpoint. And there's other, LymeDisease.org, I believe, also has a roster of physicians that they can refer to. So there's a number of different websites. And talking, frankly, to friends, maybe, as we said before, this is actually more common than a lot of people realize. So you might have, friends and colleagues who have gone through the same thing for themselves or for their children or for a family member, and, getting personal referrals also is always helpful.
Yes, I agree. Also, I should say that when I was diagnosed with Lyme, and I was diagnosed because I had a rash, but one of the things I learned was that there was a lab, part of Stony Brook Hospital on Long Island called Stony Brook Labs that does a pretty good Lyme test. If you, and it is often covered by insurance. I don't know if you use that in children.
Yes, I do. I've used Stony Brook, and I think they're an excellent Lyme lab. Another lab I should mention that I also really like to use called Medical Diagnostic Labs, MDL, based in New Jersey. I think those two labs both do excellent Lyme antibody testing, including what you want to make sure gets done is something called the Western blot or immunoblot.
Yeah.
That's considered the second tier test. Usually it's not done unless the first tier test is positive or equivocal. But I personally would advise requesting the Western blot or immunoblot regardless of the first stage result, because I think that first stage result ends up, it's too restrictive.
Yeah.
It's looking at amount of antibody. And there are some Lyme patients who are trying to make, their immune systems are trying to make antibody, but they aren't meeting that high enough level to pass first stage test. And yet if you go on to do the second stage test, you will see what are called Borrelia specific bands. So they are bands that are specific to the Borrelia organism. The bands represent antibodies being formed to proteins of the organism. And you see these on this thing called a Western blot, where the proteins get divided by or get distinguished by their size. And the different sizes are represented by these different bands. Now it's tricky, you need to have a clinician who is who's well informed in terms of interpreting the information as well.
Yeah.
So I guess my bottom line message is that the testing is more complex than what physicians are generally taught, and so you sort of need someone who takes a special interest in this to really understand the ins and outs of the different bands and which ones are specific. And ultimately, Lyme really needs to be a clinical diagnosis. This is always important because you can see someone who has positive bands on that test, but have no symptoms. Talked about that before. You can be asymptomatic, right? Or they could be leftover bands from an old infection that has been adequately treated. And so you really need to go by clinical symptoms and then say, does my lab test, is it supportive or not of the clinical diagnosis? But to make the clinical diagnosis, you need to know all the different ways that Lyme can present, right? So it's layer of complexity upon complexity.
So a lot of physicians will say, who have a lot of experience in this area like you, that they will institute antibiotics if they're not 100% sure, but the clinical picture is screaming Lyme, Bartonella, they will institute a small trial of antibiotics to see what happens. And a lot of times it's extremely informative. Do you think that that's something clinicians should do or should consider in these cases? If you have all negative tests or inconsistent tests?
I guess, what I personally believe is that Lyme disease and the associated infections and hits that go along with it needs to be a specialty area of medicine, similar to the way HIV is within infectious diseases. There are doctors who do just HIV medicine and are thoroughly versed in it. And I feel Lyme is equally complex, if not more complex. And that is my hope, that eventually that is, what will be the case. And so I don't think that a physician who doesn't have a thorough understanding of Lyme disease, the complexity of it, the kinds of responses you can see to treatment, because, and we'll get into this, sometimes you can actually see worsening before you see improvement. Called a Herxheimer-like effect. So I wouldn't say that I would advise just an empiric course of treatment. It really requires such careful evaluation, not only for Lyme disease, but to rule out all other potential causes.
Absolutely.
Yes. And then if you have ruled everything out, even if you don't have definitive diagnosis of Lyme by the lab testing, because say it is equivocal, you need, I think, to be someone who's, who's experienced with this. I wouldn't say just go ahead and give it a try because, what's the harm kind of thing. I think that you need to know what you're dealing with.
In terms of tick bites, okay, so I have an adult doctor, obviously, Stephen Phillips very well. He treats tick bites. He advises treating tick bites. I don't know what the thinking is for kids. I don't know what you think about that. What do you think?
I do. Personally, I always do. What would I do if it were me? I would treat a tick bite because the best response you're going to get is early on, usually with any infection, treating early on, preventing it from ever occurring. And so there are sort of standard recommendations for when to consider giving prophylactic antibiotics for a tick bite. And again, I think what I found is when I researched this, that, it's actually more complex and confusing than what the standard recommendations are, I think. Yeah. So for instance, one recommendation is that the tick has to be attached for 36 hours in order to transmit the Lyme spirochete. And that's because the spirochete resides in the tick's gut, and it takes that long for it to travel from the gut to its salivary glands and saliva to then get transmitted to the host. Now, while, that's generally the case, in fact, transmission has been documented with tick bites that are less than that 36-hour threshold. And in fact, Willy Burgdorfer, who was the discoverer of Borrelia burgdorferi, in an interview, he himself said, I don't really, go by that cutoff threshold because there can be ticks who are partially fed who detach from a host.
Yes.
So, they aren't fully engorged, they detach. The spirochete has already traveled from the gut to the saliva, it's disseminated, and then they reattach to a different host.
Yes.
And so you don't, in that case, according to Burgdorfer, he says you can transmit right then if the saliva is already infected with the spirochete. And that occurs, I think he said in that interview, in about 5 to 10% of infected ticks at the time of attachment. So that's that's significant, something to consider. So I wouldn't go by that 36-hour threshold or feel comfortable that if that the tick is attached for a shorter period than that, then you're home free. A lot of times you don't know how long the tick is attached.
There is a review or a study by Michael Cook, I'm sure you know about this, where he says basically there is no safe time for a tick to be attached. There is no known documented, if it's only this amount of time, you're safe. It's just simply something that needs to be debunked over and over and over. And we talk about it a lot in the book because so many people fall through the cracks with this. Well, it was only on for 12 hours. And I know because when I went to bed, I had to walk the dog through the whatever, and they know, and I woke up and I saw it. Well, I hear from a lot of these patients a couple of weeks later, and they're pretty sick. Their doctor wouldn't treat them because it wasn't attached for long enough. That's a mistake. Yes. That's not. Okay.
And also there's other pathogens that have been well documented to transmit. For instance, Powassan virus is another tick-borne infection that can be sometimes deadly. And even as little as 15 minutes. So one thing I do advise, I'm strongly considering, is if you have the tick, sending the tick for tests. I'm the kind of person I like to get data.
Yeah.
And so if you saw that, I would advise starting prophylactic antibiotics before you get those test results back, because the earlier, the better.
Yeah.
And you want to do it within usually 48 to 72 hours is described as the cutoff. But as soon as possible. And then, you can test not just for Lyme disease, but a host of different infections.
Okay. So one more thing that I feel that we need to debunk while you're here is the recommendation. I don't even know where this came from, that you should only take one dose of an antibiotic, one dose of doxycycline if you get a tick bite, and it'll prevent illness. I think it actually just prevents possibly the rash.
So the study that was done on which that recommendation is based did just look at the EM, the erythema migrans rash, and not at long-term outcomes. And as we've been saying the entire, this entire talk, that you can have this period of latency, dormancy, and then present with symptoms later on. The standard recommendation is to give single dose doxycycline as axis, but I think the group of clinicians that take this broader view of Lyme disease and and recognize the really complex, sometimes chronic illness that can develop, that will often use longer courses. And I think, justifiably so. If you're going to be able to prevent infection that could potentially cause, debilitating illness, long-term illness later on by giving a somewhat longer course of antibiotic, everything is a risk-benefit analysis. And in that case, I think, I can't say that there are well-done studies to, and again, another huge area of research that needs to be done. But yes, it's true that that study didn't optimally look for outcomes. And in fact, one thing that you can see sometimes with early treatment is that you can actually delay or even completely abrogate the development of an antibody response to the infection, so that down the road, you might not be able to detect it on antibody testing.
That's huge. That's a huge, huge thing people need to know. It's big.
Yes. So, my personal opinion is that, and I can't back it up with, randomized controlled trial, but that in terms of a risk-benefit analysis, it just knowing this organism and it's how it causes the disease it does, the mechanisms by which it can cause disease. I think it is logical to think that it could be beneficial to do a longer course.
So, parting words for physicians, your colleagues, your well-meaning, open-minded colleagues that would really like to learn more.
Frankly, sometimes if you hear that an area is controversial, don't assume that, the sort of alternative view is crazy and fringe. And actually, if you really study, study whatever the topic could be, in this case, Lyme disease, you'll often find that there are very valid reasons for that controversy and for the alternative viewpoint. I was very humbled by that experience, frankly, because I started off with a standard view, and when I think back on some of the things I said to patients, or that I discounted, that I didn't think that they had Lyme disease, because based on what I had been taught in this standard paradigm, it was supposed to be very unlikely that that was the case. And when I look back at those cases, knowing what I know now, I know that I missed some cases, and so I think you'll be really rewarded if you explore this. It's a fascinating disease, and I do think, in the same way that it's, I keep on going back to syphilis because of all these interesting parallels and overlaps. It was said that if you know syphilis, you know all of medicine.
Yes.
And in some ways, I think that that you can say that with Lyme disease too. That actually, the deeper you go into learning about it, and there's so much education that I need about Lyme disease, and there's so much research that needs to be done in the field, but you'll find that the story is much more complex and different than maybe what you had what you had been trained to believe. And I would encourage reading widely, so in addition to reading the primary literature and going back to the historical literature, because as I said before, just beautiful clinical descriptions and a lot of the early studies that were done that really, reflect the more of the complexity of the manifestations of Lyme disease. But there's also some excellent books. Of course, your and Dr. Phillips' book. But another book, that I thought that was really just so educational for me was written by the mother of some of the first children who were diagnosed with Lyme disease in Old Lyme, Connecticut.
Polly Murray, we should say. Yeah.
Brilliant woman.
Yeah.
Now passed away, but she wrote a book called The Widening Circle. Very smart, had no formal training in medicine or science, but knew from her own symptoms, as well as symptoms in her children, that there was something more complicated going on, would spend, hours and days and nights at, I think, the medical library at Yale researching and keeping copious notes, with dates on her own and her children's symptoms. And it really does a beautiful job of conveying the complexity of this illness and the confusing array of symptoms. And she just has enormous insight as someone who lived with the disease herself and seeing it in her children over so many years.
Yes.
There really is something to the intuition that both clinicians and patients develop living with this contested disease.
That's an incredible note to end on, and such an important message. I can't tell you, I've chose because I know that the light that you're bringing to this, and I know that your favorite thing in the world is not necessarily doing public interviews. You are very much a brilliant clinician and researcher and medical detective. I admire you so much. The community has been so grateful to have you and to have the credibility that you bring to this cause, being a Harvard-trained doctor and having this huge career as an HIV researcher and doctor. It's so impressive. So funny. I learn more and more about you as I've known you for years now, and I keep learning because you're so humble. I just keep learning about all the things that you do. So anyway, I can't thank you enough. And on behalf of Bay Area Lyme, we're so happy that you joined the science committee. And thank you so much for being with me today on my first podcast. This is such an honor and a pleasure.
Thank you so much. It was a real honor for me too. And I'll just say, as I mentioned before, it was a humbling experience for me. And I did learn so much from my patients and my parents and the parents of those patients. And so that's the other thing, I guess I would say, just going back to, what you recommended, I tell physicians is really listen to your patients. And again, Sir William Osler, the famous physician, he said, listen to your patients. They are telling you their diagnosis. And I think that's a very apt phrase for Lyme disease.
Thank you so much. That was a great quote to end on. Thank you, Charlotte.
Thank you.
I really appreciate it. And please come back. We can talk about more. We've got so much more to talk about. This is just the beginning. Thank you. Thank you for your time.
It was wonderful. Thank you.
Bye. Thank you for joining us for this episode of Ticktective, a program of the Bay Area Lyme Foundation. For more information and to get involved, visit us at bayarealyme.org.